It is truly my privilege today to introduce Dr. Chanu Rhee. It's an extra moment of pride for us as a medical school and as an institution, because Dr. Rhee is our own medical student. Dr. Rhee graduated from Yale University with a BA and magna cum laude in molecular biophysics and biochemistry. He then came to our medical school and graduated with a summa cum laude, and then went on to do his residency at Stanford University, where he also served as a chief resident. Following that, he did infectious disease fellowship, both clinical and a research fellowship at Massachusetts General Hospital and Brigham and Women's Hospital. He has since stayed on as a faculty at Harvard School, where he's an assistant professor. I specifically invited him here, not only because I followed his success as one of our medical students, it's because he is the lead person from IDSA. As many of you know, we in infectious diseases, we believe in antibiotics. Nobody believes in antibiotics more than the ID world does. But we also know that there are nuances about initiation of antibiotics. And so we have, as a society, looked at the quality metrics and wanted to make a partition between sepsis and septic shock. And this is not so much about care of a patient, it's about quality metrics. And I've specifically invited Dr. Rhee today to tell us some of the nuances that go into these quality metrics and what the IDSA position on this is.
Thank you so much for the introduction and for inviting me to give grand rounds today. It's a real pleasure and honor to be back at Georgetown. You know, I know we're all still very preoccupied with COVID, but nonetheless, sepsis remains a huge problem, and that's what I'll be talking about today, and in particular around mandated sepsis bundles and quality measures and why they're so controversial. Okay, here are my disclosures with respect to royalties, grant funding, and committee membership. I have no financial conflicts related to this talk. So what I'd like to specifically talk about today in terms of my objectives are to review the major lines of evidence supporting sepsis bundles and quality measures, describe some of the controversies around these mandates and limitations in the evidence, and then to discuss potential future directions of sepsis surveillance, quality measurement, and clinical care. So why am I talking about sepsis? Well, it's because it's a huge problem. Here are some statistics on the burden of sepsis just in the US. It's estimated that there's 1.7 million adults who are hospitalized with sepsis, so accounting for about 6% of all hospitalizations. It has high short-term mortality rates of 10 to 20% or higher. It's a leading cause of death in hospitalized patients. And even those who survive sepsis are not out of the woods. They're at risk for readmissions, an overall decrease in their functional capacity, and increased long-term mortality. And finally, it's the most expensive condition treated in hospitals. It's estimated to cost Medicare more than $40 billion per year. Now, I think those of us in the medical field have long been aware of the dangers of sepsis, but I say it's really over the past decade, I think, where sepsis has caught the attention of the public and of policymakers. And I think a lot of this stems from a very high-profile and tragic case, the case of Rory Staunton. Now, he was a 12-year-old boy who developed sepsis after falling and scraping his arm in the gym. He was sent to the emergency department of a prestigious academic hospital in New York City. Was sent home with a diagnosis of viral gastroenteritis, despite having an extremely high white blood cell count and bandemia. And he returned 48 hours later in fluoride septic shock, and unfortunately passed away from streptococcal bacteremia and sepsis. Now, out of that tragedy has come good in the sense that the parents rededicated their lives to raising sepsis awareness. They formed the Rory Staunton Foundation, and they helped to lobby New York State to implement new sepsis policies. I think that really helped to usher in this current era that we've been in now for almost the past decade of sepsis quality measures. So in 2013, just the next year, New York State mandated sepsis protocols in all of their hospitals, so-called Rory's regulations, and several other states have followed suit. On a federal level, in 2015, the Centers for Medicare and Medicaid Services implemented their severe sepsis septic shock early management bundle, or so-called SEP-1. And this requires hospitals to publicly report compliance in 3- and 6-hour bundles in patients who are diagnosed with sepsis. And needless to say, this has catalyzed countless sepsis quality improvement initiatives in hospitals around the country. And certainly in my own hospital in the Mass General Brigham healthcare system, shortly after the CMS measure was announced back in 2015, that's when we initiated our system-wide sepsis quality improvement initiatives. Okay, so before I talk more about the quality measures, it's important to talk about definitions and what is sepsis really. And it's interesting that this term sepsis has actually been around for apparently thousands of years. The Greeks used this term to refer to patients who appear to be rotting. Now, obviously today we made so much in terms of medical advances and knowledge, but nonetheless, we still, I think, struggle to define sepsis. And that's because it's a complex and heterogeneous syndrome. There's no single confirmatory test. And while we can all point to certain cases that are very florid and obvious, like the patient with gram-negative bacteremia who's in the ICU, that's actually a minority of cases. And indeed, most patients with sepsis do not have positive blood cultures. So it's not always easy to define and diagnose it. So it's worth it to just briefly talk about the history of sepsis definitions. And it really wasn't until 1991 when the American College of Chest Physicians and the Society of Critical Care Medicine got together and tried to put some standardization around the nomenclature for sepsis. And they decreed that sepsis is a systemic inflammatory response to the presence of infection. And that's where the SIRS criteria were first defined, which were 2 or more abnormalities of temperature, heart rate, respiratory rate, and white blood cell count, with infection being defined as infection with SIRS, severe sepsis being sepsis with organ dysfunction, and septic shock referring to refractory hypotension. 10 years later, they got together again, and while they expanded the list of possible diagnostic criteria, there's otherwise no significant change to that general framework. So that framework was in place for decades, certainly how I trained on thinking and diagnosing sepsis. In 2016, however, there was a big change, Sepsis 3. This was a task force put together by American and European critical care societies, and they redefined sepsis as a life-threatening organ dysfunction caused by a dysregulated host response to infection. And the major practical changes were that the SIRS criteria were eliminated as part of the definition of sepsis, and the prior category of severe sepsis was eliminated as this is now redundant with sepsis, again referring to organ dysfunction. And that prior category of SIRS with infection was now just declared to be infection. So in terms of how they want to quantify organ dysfunction and define it, they did it based on the Sequential Organ Failure Assessment Score, the SOFA score, which is a score that was developed back in 1996. It quantifies organ dysfunction on 6 scales: respiratory, cardiac, neuro, renal, liver, and coagulation dysfunction. And essentially, the current definition is that sepsis is infection with an increase in the SOFA score by 2 or more points. So why did they do this? Why did they redefine sepsis? Well, for as long as SIRS has been around, it's been criticized for being non-specific for infection. And lots of other things can cause SIRS physiology. And also, it's not perfectly sensitive. Some patients with severe infection and organ dysfunction also do not manifest SIRS, so they can't mount the heart rate, they can't mount the fever. And also from a pathobiologic standpoint, it's understood that SIRS is a physiological response to infection. So if you have influenza, it's normal to have fever and perhaps an elevated heart rate. But it's organ dysfunction that's what crosses the line between an adaptive and maladaptive immune response. Furthermore, it's pretty clear that the severe sepsis terminology was pretty confusing, and there have been poorly defined thresholds for organ dysfunction. So that was the rationale for sepsis theory. Like everything in sepsis nowadays, it's also been met with criticisms and controversies. And as soon as sepsis theory was published, there were editorials from prominent sepsis thought leaders basically criticizing and saying we should not make this change. And I'd say that the main criticisms I would say boil down to this, that the concern that sepsis now is focusing on organ dysfunction, and that's actually pretty late in the game in terms of the progression of infection to death. And if you de-emphasize the SIRS criteria, you could actually delay early treatment. Furthermore, we've made a lot of progress over the past couple of decades in terms of quality improvement for sepsis, so why backtrack on these definitions now? Furthermore, the SOFA score I showed you, it's a pretty complicated research, a tool that's really meant for research and prognostic purposes, not necessarily for clinical care. And even 5 years after sepsis 3, I'd say most of us don't really calculate SOFA scores at the bedside. And lastly, it's not aligned with the CMS SEP-1 definition. They did not change their definitions. And so this it leads to a period of confusion, I would say. So bottom line on definitions is this. It's the state of sepsis definitions is currently pretty messy and controversial. From my point of view, what I teach the residents and the med students is that regardless of what exact operational criteria you're using, I think we should be worried about sepsis if there's possible infection and any signs of organ dysfunction. And conversely, if patients were not initially suspected to have infection, but they develop unexplained new organ dysfunction, sepsis should be considered. I think to me, the biggest challenge in identifying sepsis is really figuring out who's infected and what is the causative organism and the source in a timely and accurate manner. And none of the sepsis definitions make any attempt to address that because it's obviously a very complicated topic. Okay, let's move on to sepsis treatment and guidelines and mandates. So I've been talking about the CMS SEP-1 measure, and here it is. So this is what the government wants us to do. Within 3 hours of severe sepsis or infection with organ dysfunction, we're supposed to measure lactate levels, draw blood cultures, administer broad spectrum antibiotics, and if for patients who are hypotensive or have lactic acidosis, to administer 30 cc's per kilogram of fluids. Within 6 hours, we have to repeat a lactate if the initial level is greater than 2, administer vasopressors if patients are still hypotensive, and then to reassess volume status and tissue perfusion and document that exam. Currently, it's an all or nothing quality measure. You have to perform all of the bundle elements to get any credit. So let's talk about where did this measure come from and a high-level overview of the evidence behind sepsis bundles. And I say it really harkens back to the Surviving Sepsis campaign. This is a international coalition of professional societies that was first launched in 2002 with the goal of improving sepsis awareness and decreasing mortality through evidence-based guidelines that were first published in 2004 and are updated every 4 years. Now, numerous studies have been published in the literature showing that implementation of the Surviving Sepsis campaign bundles is associated with lower mortality. Here's one I picked out of many of them, published by Mitch Levy, one of the founders of the Surviving Sepsis campaign a few years ago, showing that the longer that hospitals stayed in the Surviving Sepsis campaign, the lower sepsis mortality dropped, and the higher bundle compliance was associated with lower mortality. Now, the New York State Rory's regulations have been a great natural experiment, something that we can study to understand the impact of these protocols. And again, Mitch Levy and colleagues published similar findings that after the first 2 years after implementing the regulations, bundle compliance went up, risk-adjusted mortality for patients with sepsis went down, and higher compliance was associated with decreased length of stay and mortality. Chris Seymour and colleagues from the UPMC group a few years ago published this paper in the New England Journal of Medicine. And again, they used data from New York State, and they looked at the association between each hour of delay into bundle completion and risk-adjusted mortality amongst almost 50,000 patients. And the major take-home point was this, that each hour delay in bundle completion was associated with about a 4% increase in the odds of death. And this was driven primarily by delays in antibiotics. Now, the CMS team has also shown similar data. Here on the left is figures that they have shown on numerous webinars and national conferences, basically showing that amongst patients who fall into their SEP-1 measure, those who receive SEP-1 compliant care have lower unadjusted mortality than those who fail the measure. And recently, just a few months ago, they published a paper in CHEST showing that even when they use propensity score matching to adjust for confounders, this association with lower mortality with SEP-1 bundle compliance persisted. Now, over the past several years, I think all of these apparent successes of the bundles have led to even more ambitious goals. And in 2018, the leaders of the Surviving Sepsis campaign put out an interim update, what they call the Hour 1 bundle update, saying that all elements of the bundle should be initiated within 1 hour of ED presentation. So even more aggressive time targets for the bundles and antibiotics. So with all that being said, I will say that SEP-1 has not been universally embraced, in fact, far from it. And many people, including myself and my colleagues, have written editorials in various journals, sort of talking about the limitations and issues with the measure. And the resistance to the Hour 1 bundle has been just as fierce, if not more. And here you can see in the middle there, the American College of Emergency Physicians felt so strongly that they recommended that the hospitals not to implement the Hour 1 bundle. And Paul Merrick actually had a pro-con debate in CHEST talking about whether or not the Surviving Sepsis campaign guidelines should be retired altogether. And as Dr. Kumar alluded to in the beginning, I had the privilege of serving on this task force, the sepsis task force sponsored by the Infectious Disease Society of America, where we talked about the evidence and concerns around the SEP-1 measure and our recommended revisions. And this was endorsed by several other professional societies, including the American College of Emergency Physicians. Okay, so what are the concerns and controversies? Well, there's a lot of them, but I'd say it really boils down to these three biggest concerns. One is the risk of promoting indiscriminate antibiotic use and all their adverse consequences. And clearly that's of great interest to ID physicians and the ID Society. The limitations in the evidence supporting the bundles, and challenges in quality measurement and sepsis surveillance. So let's talk about the first one. So sepsis, it'd be nice if sepsis was like other emerging conditions that are easy to recognize, like severe trauma, or that have a rapid and accurate biomarker, like myocardial infarctions and troponins, or have highly accurate imaging tests like strokes and CT scans and MRIs. But of course, none of this is true for sepsis. It's a very heterogeneous syndrome, and some patients certainly are obviously septic, but a lot of them can be difficult to diagnose. And this is a study, we and others have quantified the uncertainty in sepsis diagnosis. This is a paper we recently published in Critical Care Medicine. It was a simple study. We looked at 300 patients who were treated in the ED of 4 US hospitals and were treated with intravenous antibiotics for presumed serious infections and sepsis. And we use all the data after the fact throughout their hospitalization, everything that we had available to adjudicate the likelihood of bacterial infection. And the bottom line is about a third of patients had no or little convincing evidence of bacterial infection in retrospect. And other studies have shown similar things. And the concern is if we force immediate treatment for a condition with this much diagnostic uncertainty, to what degree are we risking overtreatment? Now there's lessons from the past that we can draw from. Analogies have been made to the CMS Community-Acquired Pneumonia Measure from the early 2000s that required clinicians and hospitals to administer antibiotics within 4 hours of patients with community-acquired pneumonia after arriving to the ED. And this was also based on retrospective analyses suggesting better outcomes with faster time to antibiotics and patients who were ultimately diagnosed with pneumonia. But when the rule was applied prospectively and clinicians had to deal with all the challenges of differentiating pneumonia from many other respiratory syndromes, it didn't work out as well as planned, and some of the consequences included a rise in misdiagnosis and inappropriate antibiotics. In fact, many ED physicians just admitted that they would prescribe antibiotics to patients who, on balance, they felt probably didn't have pneumonia, but they didn't want to risk failing the measure. There was no change in mortality rates for patients with pneumonia, and there was a report of nosocomial C. difficile outbreaks associated with intensive pneumonia treatment guidelines. And of course, the concern is that sepsis is even more complicated and heterogeneous than pneumonia. Now, I think we'll see more and more studies on this, I think, in the coming years, but there's already several studies that have been published suggesting that there has been increased use of broad-spectrum antibiotics after implementation of SEP-1. Again, I think we'll see more and more of this in the years to come. Let's talk more about the limitations and the evidence supporting the bundles, and in particular focus on time to antibiotics. So really, this is the first frequently cited time to antibiotic study for sepsis, Anand Kumar's famous study from Critical Care Medicine 2006, showing that every hour delay in antibiotics was associated with an 8% absolute decrease in survival. But it's important to know that the cohort focused exclusively on patients with septic shock who received antibiotics after the onset of persistent or recurrent hypotension. So the question is, does this apply to sepsis without shock? Now, if you go back to Chris Seymour's study that I showed a couple slides ago in the New England Journal of Medicine, remember this is the big one that looked at the Rory's regulations and showing that each hour delay in bundle completion was associated with a 4% increase in the odds of death. If you look at the subgroup analyses, interestingly, that mortality signal was only there for patients with septic shock as marked by the need for vasopressors. And you can see that those who did not require vasopressors, there was no real signal for mortality benefit or detriment with delayed antibiotics. Similar findings were also published by Vinnie Liu and colleagues in the Blue Journal a few years ago, where they looked at 35,000 patients in the Kaiser Permanente Northern California cohort. And what they found was that amongst those with septic shock, those are the patients that had the greatest absolute increase in mortality with every hour delay. And that mortality increase was much smaller and barely statistically significant for those with severe sepsis and sepsis. Now, the only randomized controlled trial that has looked at differential antibiotic timing for those with sepsis, and by the way, that's hard to study in trials because arguably it's unethical to withhold antibiotics, if you think a patient has sepsis, right? But the way that they did this study in the Netherlands was they enrolled 2,700 patients, and they enrolled them to compare early antibiotics in the ambulance, primarily with ceftriaxone, versus usual care in the emergency department. And while they were successful in giving antibiotics earlier, on average about an hour and a half, there's no difference in the primary outcome of 28-day mortality. However, this is primarily a cohort of patients who did not have septic shock. Less than 4% did. So it's worth reiterating this again. The only randomized controlled trial of differential antibiotic timing in sepsis patients, primarily non-septic shock, did not show any mortality benefit. So what am I getting at here? What are the implications? I would say it's this. If infection is merely one of several potential diagnoses, and the patient is not in shock or critically ill, and I think in many cases, we have some time to at least get the workup started. And even a few short hours can often provide more diagnostic clarity, or at least inform a more thoughtful choice of antibiotics rather than mank cefepime all the time. Conversely, antibiotics should be given promptly if infection is clear-cut or probable. So there's no reason to withhold antibiotics if it's pretty clear they have an infection, or the patient is in shock and there's any possibility of infection. I think all of us would agree that this is a group where we have no margin for error, and we would just give the antibiotics empirically. So let's talk about the non-antibiotic interventions of SEP-1. And here's a systematic review published by Dominique Pepper and colleagues from the NIH. And they looked systematically at things regarding the 30 cc's per kilogram fluid bolus, serial lactates, volume status exams, bedside ultrasounds, fluid responsiveness testing. And just to jump to the chase, their conclusions were that none of the 17 studies that looked at these were free of confounders or at low risk of bias. In 3 of the randomized trials, fluid responsiveness testing did not alter survival. And in summary, no high or moderate level evidence supports the hemodynamic interventions of SEP-1 to improve sepsis mortality. Now, I think the 30 cc's per kilogram, aside from the time to antibiotics, I think this is probably the most controversial aspect of the sepsis bundles. And the reason is that this 30 cc's per kilogram threshold has not been rigorously studied in trials. We know there's potential for fluid overload, and particularly in patients with heart failure, end-stage renal disease, and respiratory dysfunction. I think over the past decade, there's been a lot of evidence emerging about the harmful effects of over-resuscitation and positive fluid balance, and evidence that earlier initiation of vasopressors may be beneficial. Going back to the New York State analysis by Chris Seymour and colleague, remember the association with outcomes is really for antibiotics and the bundle completion as a whole. But when looking at time to completion of the 30 cc per kilogram fluid bolus, there was no association with this and mortality. Okay, so I want to delve a little bit more into the evidence around these bundles. So remember, there's studies like the one I just showed you showing that if you have bundle compliant care, you have lower mortality. So what are the explanations for this? So one is that bundle compliance reduces sepsis mortality. So there's a causal relationship, and that's certainly what the proponents of sepsis bundles and mandates would put forth as an explanation. The second one is that it's not necessarily the bundle itself, but it's really just a marker of better global quality of care. So if you comply with the bundles, your overall hospital care is probably better. I think the last one that's been less talked about is that the patients who receive bundle compliant care are fundamentally different than those who do not. So what do I mean by that? So here's a study that my colleague Mike Philbin, an ED physician in Mass General, and I was part of this study. We looked at presenting symptoms amongst patients who were ultimately diagnosed with septic shock. And we categorized patients as having explicit infectious symptoms, so things like fevers, chills, rigors, productive cough, things that would immediately clue in the treating teams for the possibility of infection and sepsis. And those who presented with vague symptoms, things like altered mental status, weakness, fatigue, malaise, abdominal pain, etc., without any explicit symptoms. And what we found is that the explicit symptoms, again, were more likely to have sepsis recognized and receive timely care. That makes sense. They also tended to be younger and healthier. And those with vague symptoms were less likely to have sepsis recognized and bundles applied. And they were older and sicker. And even when accounting for time to antibiotics and other confounders, having vague symptoms of presentation was powerfully associated with worse mortality. I bring this up because most prior observational studies of sepsis bundles have not accounted for presenting symptoms. So this is a very important unmeasured confounder. To drive this point home, this is a study my colleagues and I published also a few years ago. We looked at over 800 patients who fell into the SEP-1 measure. And overall, there was a 33% bundle compliance rate. And the crude findings were just as you'd expect. The patients who received SEP-1 compliant care, their mortality was a lot lower than those who failed the measure. But when you delve into those patients, you can see that those who receive SEP-1 non-compliant care tended to be a lot sicker. They are more likely to have septic shock. And that makes sense because there's more bundle elements you need to pass for the septic shock measure. They're more likely to have hospital onset sepsis, and we know those patients are sicker and have a higher mortality rates. And they're also 30% more likely to have vague presenting symptoms. And then when you looked at the crude odds for hospital death, and then you adjusted for all those things, including presenting symptoms, that signal was markedly attenuated. So in other words, you need very detailed risk adjustment if you want to try to properly assess the associations between bundle compliance and mortality. And I'd say most of the studies to date have not done that. All right, so let's talk more about quality measurement and surveillance. So I've been talking about the SEP-1 and definition. So here is the time zero definition that everything hinges on for the SEP-1 measure. You need to have all three of the following within a 6-hour window: documentation of suspected infection, 2 or more service criteria, and one of many different potential organ dysfunction criteria. Or the clinicians documented their note that they're suspected severe sepsis or septic shock. That will trigger time zero, even there's no objective criteria that are met. So if you ever, for the abstractors have to abstract the measure, they know that this requires juggling between nursing flow sheets, laboratory data, and progress notes, often multiple versions of the same note to try to find time zero. So begs the question is, how reliable is SEP-1 time zero abstraction? So we looked at this with a very simple study. We pulled 80 SEP-1 cases, and we had 3 different abstractors review them from 3 different hospitals. And the bottom line is that the concordance for time zero was actually quite low. Only 36% of the time did they agree to the exact minute of what time zero was. When you expanded that window to 1 hour, it was a little bit better, but still not great. And even when looking at a 3-hour window for time zero, there was only 68% concordance. And now, surprisingly, then, the apparent SEP-1 compliance rates amongst hospitals varied greatly amongst the abstractors. I want to talk more about sepsis surveillance, and I showed you a bunch of the studies showing that bundle implementation leads to decreases in mortality rates over time. And this has to be coupled to the reported rise in sepsis rates over time. So this is Greg Martin's famous study from the New England Journal of Medicine 18 years ago now, showing a dramatic rise in sepsis incidence over time. And this was also coupled with declining case fatality rates over time. And many, many studies have published the same thing. Here's another paper in Critical Care Medicine 8 years ago showing even when you use 4 different administrative definitions of sepsis, they all may give different point estimates year to year, but they also show the same trends of increasing incidence over time and declining case fatality rates. So what are the explanations for this? So the common explanation for why sepsis incidence appears to be rising is that we have an aging population, we're doing more and more medical procedures, we're giving patients a lot of chemotherapy and more advanced immunosuppression, and perhaps there's more antibiotic-resistant organisms. And of course, for the decline in sepsis mortality rates, that's typically attributed to improvements in sepsis care and the use of sepsis bundles, right? An alternative explanation, though, is that we may just be simply diagnosing sepsis more often than we used to. So we looked at this. This is a prospective article we published a few years ago in the New England Journal of Medicine. And we looked at a national administrative database, and we looked at hospitalizations with primary infectious diagnoses. And what we found was that, again, sepsis or septicemia rates almost tripled during this time frame, like other studies have shown. But when looking at the infections that most commonly lead to sepsis, like pneumonia, intra-abdominal infections, UTIs, and bacteremia, they are all stable, or in the case of pneumonia, actually decreasing. So to us, this suggested that this rise in sepsis incidence may reflect an increasing preference for labeling infections as sepsis. So in other words, potential coding artifact. And this makes sense because sepsis has been increasingly in the spotlight over the past 2 decades. There's education and awareness campaigns, there's new sepsis screening protocols, there's efforts to improve diagnosis and documentation. And frankly, there's also financial incentives to code for greater complexity, all of which are shining more of a bright light on sepsis over time. So with respect to QI initiatives, this is the concern. So when you implement a QI initiative, this is typically accompanied by a lot of these efforts to improve diagnosis and documentation. And so what you'll typically see is an immediate rise in sepsis incidence because of a lower threshold for diagnosis. And then you'll see an immediate decrease in sepsis mortality, which may be due to better care, but may also be because you're including less severe cases in your denominator. So I want to just go back to the New York State data, and let's just see if this could be happening there as well. So this is the paper I showed you showing, again, declines in sepsis mortality after Rory's regulations. And the black dots show the risk-adjusted mortality rates. So first of all, in Q2 2014, there were 8,600 cases that were reported. And just 1 year later, there were 1,100 cases that were reported. This is a 30% increase. So already gives you a hint that you may be seeing this ascertainment bias that I'm talking about. Now, when you put a line through the observed mortality, for the, you can see that that line is a lot steeper. So in other words, the risk adjustment has flattened the mortality curve. But again, risk adjustment is imperfect. Here, their area under the receiver operating curve was 0.77, which is decent, but far from perfect. And it begs the question, if risk adjustment was perfect, how much flatter would that mortality trend line be? Okay, so what then should be the target for sepsis bundles and quality measures? So here's IDSA's major recommendation to revise SEP-1. And it's simple. We recommend that the measure eliminates severe sepsis or the sepsis category and focus on septic shock. And the rationale was as follows. This is the area of consensus. Hopefully I've convinced you that this is the strongest evidence in terms of that patients with septic shock will benefit from prompt antibiotic administration, or conversely, they will suffer harm if you delay antibiotics. We also think this could help to mitigate the risk of indiscriminate antibiotic prescribing if we message that we can de-emphasize immediate broad-spectrum antibiotics in this larger and more heterogeneous bucket of sepsis to allow for slightly more breathing room to inform more thoughtful antibiotic prescribing. I think also from a quality measure standpoint, it will also simplify time zero abstraction and increase reliability of the measure. So to be clear, it doesn't mean that we don't think sepsis without shock is an important group, but it's more that we think that a uniform treatment standard for this category is problematic because it's so heterogeneous, it's difficult to define this population. There's too often uncertainty about whether or not infection is truly present. And again, I think there's insufficient data on the necessity of immediate antibiotics for most of these patients. And so we recommended that guidance around managing sepsis without shock is better left to best practice guidelines rather than a mandatory national quality measure. Now, on the topic of best practice guidelines, actually the Surviving Sepsis Campaign guidelines just released their most recent iteration. And we were happy to see a lot of these ideas and recommendations actually folded into their guidelines. And here's sort of a figure that summarizes their recommendations on antibiotic timing. And it's pretty much just as we stated. So they break it down into the presence of shock or not. And the patient's in shock, even if your level of suspicion is not that high, you don't have time to wait, and you should give antibiotics ideally within 1 hour. If shock is absent, then it depends on your certainty of infection. So again, if sepsis is definite or probable, even without shock, no reason to withhold antibiotics. You should give it as quickly as possible. And it's in that low likelihood category where there's more nuance, where they now recommend doing a rapid assessment of potential non-infectious causes and potentially non-antibiotic interventions. And then if you're concerned for infection persists, then to give antibiotics within 3 hours. Now, I know that it seems like maybe it's all pretty subtle, and how much impact will this truly have? And I share those concerns, but I think this is a step in the right direction, in my opinion. All right, I want to talk a little bit more about sepsis surveillance. So hopefully I've convinced you that the traditional methods of surveillance, particularly using administrative data, are not very reliable. So begs the question, what's the better way to do that, to track sepsis over time? And so this has been a particular research interest of mine and my colleagues over the past many years, making sepsis surveillance more objective using clinical data that can be extracted from electronic health record systems. So looking at markers of presumed infection like blood culture draws and antibiotics, and concurrent organ dysfunction like vasopressors, mechanical ventilation, and clearly defined changes in baseline laboratory values without having to rely on physicians to diagnose sepsis and coders to code for it. Now, we published a few studies early on, pilot data showing that EHR-based surveillance is more accurate than administrative data relative to medical record reviews, and it generates more stable estimates of sepsis trends over time. This is a great interest to CDC, and they funded us to do this multi-center collaborative study a few years ago, where we partnered with a lot of different folks around the country, including members of the Sepsis 3 task force. And our goal was to create a surveillance definition that's based on the Sepsis 3 framework of infection and organ dysfunction, but using objective and routinely available electronic health record data, and then to apply the definition to diverse hospitals to generate the most credible estimates of current US sepsis burden to date. Basically, CDC said, we don't believe any of this administrative data in terms of sepsis burden, so we'd like you to give us more accurate estimates. So when we developed this CDC sepsis surveillance definition, here are sort of principles. We adapted sepsis 3 and the SOFA score to facilitate wide-scale retrospective surveillance. So this is not meant to be used in real time, but again, after the fact, to determine whether a patient who was hospitalized had sepsis. And we wanted the definition to be as objective as possible and to use measures that are things that are routinely measured or used to treat sepsis, easily ascertainable from different EHR systems, and could be applied consistently and uniformly over time and place. So here's a definition that we developed. So the algorithm, it's basically an algorithm that looks for a blood culture order regardless of result, looks within a plus or minus 2-day window, looks for the start and continuation of antibiotics for at least 4 days, and then looks for organ dysfunction within that time frame as well. So new vasopressors, new mechanical ventilation, and well-defined changes in creatinine, bilirubin, or platelets, or an elevated lactate. And if all these criteria are met, this is a sepsis event. Now, we validated this with many medical record reviews against sepsis 3 criteria, and again, showed that this was not perfect, but more accurate than administrative codes for sepsis. So we applied these criteria to over 400 hospitals, so about almost 3 million patients. And we found that sepsis was present in about 6% of all hospitalizations, most of which were present on admission, over half of whom required the ICU, and 15% died in hospital, and another 5% were discharged to hospice. And when we projected these case counts to all US hospitals to develop national sepsis estimates, these are the numbers that we got. 1.7 million adults in the US each year, 270,000 associated deaths, and one in 3 patients who die in the hospital have sepsis. And you can see these are the numbers that CDC has on their website. Now, importantly, when we apply these data to 5-year trends to look at data from 2009 to 2014, you can see that when we use 2 different administrative definitions, you can see again, they yield quite different point estimates year by year, but the general trend was a dramatic increase over time. And then when you use this clinical definition, that increase was basically stable over time. And similarly, when looking at short-term mortality, death or discharge to hospice, we use administrative definitions that suggest that we're improving over time, year by year. But over this time period, there was a non-significant change using the CDC definition. Okay, so this work led to CDC's Adult Sepsis Event Toolkit that was released in 2018. This is right now a non-mandatory surveillance tool with the goal of helping hospitals that are motivated to more reliably track their sepsis rates and outcomes using objective data. And the reason I harp on this is I think it's so important. As CDC says, it's really surveillance and data are the foundation of public health practice. And that's certainly true in the COVID era. Think about how much we base sort of our policies around COVID numbers and case counts and deaths. And that's certainly true for sepsis. Put another way, I think it's really difficult to make progress without having a reliable measuring stick. And that's what this tries to do for sepsis. Now, we and other investigators have used sort of a similar concept of using EHR-based surveillance to tease apart the impact of the SEP-1 measure. So this is Ian Barbash and the UPMC group. They published this earlier this year in the Annals of Internal Medicine. And there are 11 hospitals in the UPMC system. They tried to see whether implementation of SEP-1 in 2015 had any impact. And what they found was that it was associated with large increases in lactate testing, small increases in fluid boluses and broad spectrum antibiotics, but did not have an impact on mortality trends. This is another study that's in press right now, and our group, we presented this at ID Week recently, and we expanded that analysis to over 100 hospitals using EHR data, almost 120,000 patients with clinical evidence of suspected sepsis. And we looked at the same thing. What was the impact of the SEP-1 measure? And similar to the UPMC group, we also showed that immediately after the SEP-1 measure was implemented, there was a large increase in lactate testing rates that then sort of leveled off. But when looking at short-term mortality rates, you can see that before and after the measure, there was no change, no association with the SEP-1 measure. Okay, so I realize maybe I've been sort of a Debbie Downer. I've kind of told you that maybe the bundles don't work as well as we thought. We're not really changing sepsis mortality again as much as we thought. So I want to end the talk by talking about things beyond bundles, some recent and potentially forthcoming advances that at least have me excited about the field of sepsis. And the first is this paper a few years ago from the Vanderbilt group, the SMART trial. There was a cluster randomized trial of almost 16,000 patients in their ICUs, and they basically alternated month by month whether or not they're giving critically ill patients normal saline or balanced crystalloids like lactated ringers for their normal resuscitation. And what they found was that there was a 1% absolute improvement in their 30-day composite outcome of mortality or renal failure with balanced crystalloids. And this was actually driven mostly by a signal towards lower mortality. And then when looking specifically at those who were diagnosed with sepsis, there was a significant lower 30-day in-hospital mortality with balanced crystalloids. I bring this up because I think this is really exciting. This was something that immediately changed practice. Certainly in our hospital, we immediately changed from normal saline to lactated ringers for our standard resuscitation. And it's amazing if you think about how central and how many patients get fluids, around the country in hospitals. I think this is something that is having a major impact. On the topic of fluids, I've talked a lot about sort of the controversies around 30 cc's per kilogram of fluids. And this is a randomized controlled trial that is still enrolling, the CLOVERS trial, that seeks to shed more light on that in terms of what's the right balance between early fluids and early vasopressors. And basically it's enrolling, randomizing patients with septic shock to either get vasopressors early or to get a large amount of fluids before vasopressors. So I'm really looking forward to the results of this trial. Just want to talk about antibiotics. I think there's a lot of focus on time to antibiotics. I think another aspect that's important is how you deliver the antibiotic, in particular, Beta-Lactams, which of course are the backbone of antibiotic therapy, and whether you give it by a standard 30-minute infusion or whether you do it longer, so these extended infusions that are 3 to 4 hours, or even continuous infusions. And the rationale for these extended infusions is that we know that Beta-Lactams have sort of a time-dependent killing, so the longer they stay above the minimum inhibitory concentration of the bug, it has a greater bactericidal effect. And it just has better pharmacokinetics. Doesn't seem to also lead to higher toxicity. There have been many studies that have been published on this in general. I showed this meta-analysis of 3 trials that were specifically focused on critically ill patients with sepsis, and you can see that the meta-analysis showed a reduction in mortality associated with extended or continuous infusions of Beta-Lactams. Now, granted, I think that's not a large number of patients, so I think we need more data. And that should be coming soon in the form of the BLING-3 trial, the Beta-Lactam infusion group, or BLING trial, BLING-3. And this is a prospective multinational trial that seeks to enroll 7,000 critically ill patients with sepsis. It's another trial that I'm really looking forward to. A lot of interest in artificial intelligence and mining electronic health record data, lots of it around early prediction of sepsis. This is another study a couple of years ago published in Nature Medicine that I thought was interesting, that actually tried to see if we can use AI to guide better treatment strategies for sepsis. And what they did was they developed a computational model using EHR data from 17,000 patients with sepsis, and to suggest optimal fluid and vasopressor administration strategies. And then they validated it in a separate, very large cohort. And what they called the AI clinician ended up recommending less fluids and higher vasopressors compared to what physicians actually prescribed. And interestingly, outcomes were better when the treatment given by the physicians matched the AI clinician's recommendations. Now, clearly, this is all sort of early phase, is all retrospective. We certainly need prospective validations to see if this is truly useful for us, and those type of validations are underway. So again, looking forward to that. I think big picture, what I think will really move the needle for sepsis care and outcomes is just better diagnostic tests for infection. I mentioned early on in the talk that I think that's often the biggest challenge. What organ dysfunction criteria use, what thresholds? I think that is less pressing to us as clinicians, is whether the patient in front of us has an infection, what's the organism, if it is a bacterial organism, is this something that's resistant to antibiotics? Those are the questions that we need to know, and the faster the better. And I think that's really been brought to light. The importance of rapid diagnostics has been really brought to light with COVID, right? Think about how much that first COVID test really affects everything in that patient's care is starting from what type of room they're going to go to, what type of treatment they're going to get. And I think things like the BioFire PCR panel, which is a rapid sort of a panel of many different respiratory viruses, I think that's a step in the right direction. A lot of interest in biomarkers for bacterial infections, so just saying, does this patient have a bacterial infection or not? I think procalcitonin, I'm personally a fan. I think it's pretty good and it's useful, but it's certainly not perfect, and I think we can do better than procalcitonin. There's been some studies looking at the utility of rapid phenotypic or PCR antimicrobial susceptibility testing for when a patient does have a positive blood culture. So for example, a patient comes in, a day later they're growing gram-positive cocci on their blood cultures. You have this rapid test tells you it's an MRSA or not, and that can really help to tailor your antibiotic therapy. And then lastly, what I think is really exciting is this next generation DNA sequencing on blood or other sterile sites. The Carius test is one example of that. Certainly at the Brigham, we've been using this more and more, particularly when our standard diagnostic tests are unrevealing. And I think there's an expanding list of potential uses for this technology. And then lastly, I just want to talk about the future of sepsis quality measures, which I think is going to be more focused on outcomes rather than process. I think an objective EHR-based surveillance could serve as a foundation for a sepsis outcome measure. And in fact, CMS is currently working on such a measure. But I think we either replace or at least supplement SEP-1. And I think overall, this is a good move, because outcomes is what we really ultimately care about, right? And benchmarking hospitals and sepsis outcomes could help to drive further innovations in care beyond just the initial bundles of care. I think there's, in some senses, too much focus on just those first 3 to 6 hours. And the care of a septic patient I think is much more complicated than that. But of course, for a sepsis outcome measure to be useful, it will require very rigorous risk adjustment to account for the vast heterogeneity in sepsis and differences in hospitals' case mix. Okay, so that was a lot, I realized. I want to just summarize it all in 2 slides. I would summarize it as follows. First, sepsis is a leading cause of morbidity, mortality, and costs. I think state regulations and national quality measures understandably seek to improve sepsis outcomes by mandating compliance with these sepsis bundles. That being said, SEP-1 and the R1 bundle have been highly controversial because of concerns of, first, how do you even define sepsis? The potential to encourage overuse of broad spectrum antibiotics, and limitations in the supporting evidence. Hopefully I've convinced you that there's stronger evidence for tying to antibiotics and septic shock compared to sepsis. And again, we have to consider the many potential confounders in these observational studies that assess the impact of bundle compliance. And the unreliability of quality measurement and surveillance, whether it's time zero or the potential ascertainment bias in assessing sepsis trends and in outcomes. I think objective electronic health record-based clinical surveillance, like CDC's method, and they can provide more reliable estimates of sepsis burden and trends. And indeed, EHR-based surveillance suggests that sepsis incidence and mortality has been more stable over time than previously believed, and that SEP-1 probably hasn't led to improved sepsis mortality rates. I think future national quality measurement efforts are likely to focus on sepsis outcomes rather than process measures. Again, I think this will be a good thing to help catalyze broader efforts to improve sepsis care, but again, will require a very robust risk adjustment and an objective and credible denominator. And lastly, I think it's pretty clear that knowledge about how to best diagnose, treat, and track sepsis continues to evolve, and we should all stay flexible, humble, and question traditional dogma.